Get set. We are ready for the cream. On your marks. Get set. We are ready for the cream.
Alala, people who are using drugs, Pezulu. Pezulu, ngama sexual cars, Pezulu. Pezulu, ngama KP, Pezulu. Nale umzabalazo yasivume nale umzabalazo yasivume onkenda ho nale oso nale nale oh hume onkenda onkenda ho onkenda ho nale onkenda ho onkenda was me onkenda ho nale onkenda ho onkenda ho nale oh nale alala kipyalala.
Thank you very much. And we hand over to our esteemed Jabu Sibego to start us off with our program this morning. Say right, comrades. Are we all alive? Are we happy to be here? Is it good to be here? Awesome. Great. Good morning, colleagues. Ngiyazwakala? Ayizwakali? Am I audible? Okay, good morning, colleagues. And welcome to the second day of our National Key Populations Health Summit. I hope that you all had a rested night and that you didn't party too much. But welcome to you all, and it's great to have you all back into this room. So I'm going to be taking you through the agenda. Both Nonhlanhla Mkhize and I will be managing the program today. So I'll be sort of taking you through the first session, and then Nonhlanhla will be handling the second session of the program. So today we are hoping for our first plenary session. It will be around policy and legal frameworks, where we look at decriminalization of sex work. I think a topic that is very close to all of our hearts, that, you know, we've been involved with the process, but now we need to know where we are and where are we taking the conversation, and that will be presented by Ms. Kholi Buthelezi. Then we had also invited our Deputy Minister, who is also very passionate about the work we do amongst the key population space, Steve Litsike, but she could not be with us today. They are still checking her availability, but I know that she's very committed and she would have wanted to be a part of us today. Then we're going to have a presentation from Ms. Leanne from SHE around transgender issues. And then we're going to have Charity Munareng talking about policies that support and don't punish when it comes to people who inject drugs. Then we'll also have a session on law and human rights by Thabo Majucha. I think he's the only one that's missing in the panel. Where is he? Oh, great, there you are. Welcome. And then we're gonna go into our second plenary session, which is around sustainability of key population programs. And we're going to look at the funding landscape. So we'll have a presentation from SANAC by Bilia, looking at the funding gaps, and then we'll have an online virtual presentation from Colleen Daniels around harm reduction from Harm Reduction International. And then we'll have a presentation from the National Department of Health through Regina Maitufi. I think she said she might also join virtually for this session. And then we're going to have COSAP presenting on their funding landscape by Mr. Luvwani Nemutenga from the city of Tshwane. And then we'll have our panel discussions. And then we're going to have 2 breakaway sessions for today. One session focusing on the Yankee population guidelines, which are currently being developed by SANAC. And then a session on the rights and the needs of the transgender community, moderated by Leonie. And the Yankee population guidelines are moderated by myself. Then we're going to have lunch. And then we're going to have a SANAC CEO coming to give us the closing remarks. And then we'll have the summary and key next steps from our technical support unit lead at SANAC by Nati Sohaba, and then the closing by MC. So to begin our session, I'd like to call upon Ms. Koli Butelezi to take us through the decrim process. Thank you. Okay, great. Hey, lento yawo angazi MC yenziwa kanjani? Oh, sengiyicishile futhi I don't know. Technology.
Yabona kodwa aside yami inkinga. Then when you just move a slide then.
Can we go back to the first slide?
Mina ngizolenzela lapha mina I'll move it here.
So the first one is which one? First one.
Yeah.
I find what they are. Go back to your first one.
Ile. No. Yeah, that's the one.
So we just press from here.
Noma ngipressele mina ngizosebenzisa la. You can give it to Tabu to do that because he's sitting down. Hayi maqabana nginizwa. Hey, bayadjust kanjani lento le? Okay. I ngathi right. Yeah. It's 9:34. Yeah. Hey, isandla sami stick, yeah. Good morning, South Africans. Good morning, everyone. Molweni, Dumelani, Potani Mawetu, Absheni, Khuyamore, Mense. Ngishiye ubani konje, bathini nda. Onye yes. Thank you so much for the spirit. I see today we're all lively. So today I'm going to be delivering the presentation on the roadmap of the decriminalization of adult consenting sex work in South Africa that we are advocating for as Usisonke National Sex Workers Movement. So in my presentation, I thought of giving you a background because I know that some of you might not know what is the current law in South Africa that governs sex worker sex work in South Africa, because there's 4 types of legal model that I'll quickly share with you so that you can get a sense. But also I think for me, it is important that you understand why are we calling for the decriminalization and why not other legal model in South Africa. So the current law situation in South Africa, I'm sure you have witnessed that sex workers are getting arrested unlawfully most of the time. It is because sex work in South Africa, it is currently criminalized. If you sell sex, you engage into sex work, you are recognized as a criminal. So in South Africa, the Morality Act of 1957 was remained the Sexual Offense Act in 1957 that prohibit all aspects of the sex work related. For an example, if then I'm engaging into sex work and my cousin knows and my cousin benefit from me, or my mom knows that I'm doing sex work and she also benefiting from that man, as per the current law of sex work in South Africa, they are also criminals, same as I am a criminal, as per law. This apartheid era law continues to criminalize all forms of sex work and associate activities till today. Imagine in 1957, to date, I was not even born. Maybe my mom and father, they were still planning me somehow. So, but here I am, I'm advocating for the removal of that apartheid era law. So, we're talking democracy at the same time in the country, and definitely sex workers are not enjoying any of that democracy, because the democracy was changing the apartheid era. But then this aspect on sex work specifically, it was left behind. Additionally, the several multiple municipality bylaws are misused by authorities to prevent the sex work from occupying public spaces or loitering and offenders, and also often to find. So if I'm arrested, even if police did not find me in the act, because as per the current law, they should arrest me if they find me in the act. And that is hardly happening, because the service that we render is private, whether in business or not. There's no one who's doing sex work in public, or sex, engaging into sexual intercourse in public. But we find that the municipality bylaws, sex workers will be arrested when we go check them, and then we will be told that they misuse the municipality bylaws. If you pee on the street, I need to know that in the country, that is loitering. So those are type of laws that are being used in order to arrest the sex worker. So that's the unlawful that we are fighting for, because they've never caught a sex worker in the act, because as per the current law, there are 2 things that they need to have as a proof that I'm a sex worker. To caught me in the act, but I don't know if they'll keep me with my client like that, to the police station till we appear to court. And then the second one, police pretended to be clients. It's called entrapment money. So when I'm preparing to do the services, and then the police will show me the police card to say he is the police. So those are 2 proof that they need to have. So most of the time, sex workers are not get to be arrested with that. So then the use of the municipality bylaws, public nuisance, loitering, those are laws that have been used. And I think in one of the sessions that we were in yesterday, one of my fellow did actually indicated that she was nominated to serve in some of the structures within the MEC in the province, but because they to check the, what is it called? Yes, a criminal record. They picked up that she was arrested before. So that then also makes it difficult, even if sex workers would want to exit the industry, because voluntary, if they want to exit, because of those unlawful arrest of use of loitering and the municipality bylaws, and then we end up having the criminal cases under your name. So you hardly get a job. One of my colleagues in Cape Town, I remember she got a job where Robben Island. They check the criminal record. She lost the job because of, she was arrested, I think back then, 1970 something. So all these laws are apartheid era laws that were originally used to control and regulate the movement of people or of color, and are now currently being used to harass, abuse, unlawful, and profile and arrest and detain sex workers. So that's a brief of the law. So it is important, I think, that you get to understand this history, so that in your spaces, wherever you are, when you're advocating for us, and then you know the background, and you're able to have that advocacy background in fighting and advocating for our rights. Okay. My hands are sticky, yes. So there are 4 legal models on sex work, right? There's a criminalization, which is the current law, and then there's legalization, and then there's also a decriminalization that we're advocating for, and there's legalization. So in each slide, I'll just be quicker to take you through what it means. So, I mean, I've said already that under criminalization, if you buy, you sell, brothel keeping, and knowingly living of profits, you are recognized. If one does not disclose, if someone is a sex worker, you can also be arrested. The criminalized under Sexual Offense Act of 1957. And then it was amended in 2007. So the meaning of amendment of this law, it means that then the client also was then recognized also as someone that was a criminal. But the clients are hardly being arrested, right? Because why? Police are, not all police, some of police are benefiting because they would then threaten clients to say that you will tell your family that you will be caught you in the sex work business rendering services, and then they have to pay bribe. You know, so the sex workers bribe almost is not too much. And then they just put us in the van. But for the clients, they will have to bribe with 3,000 and all those kind of amounts. So that is also unfair because we also don't want our clients to be arrested. And yet this is our business, right? But the law also has been misused in this aspect because I think, if I remember, I once checked with one of the lawyers that we were working with to say, can you please give me some information of how many clients have been detained for rendering the services of sex workers? I think there were 11 cases. But if I were to tell you how many times sex workers have been arrested, you'll be surprised. So this is the legalization, right? The legalization, buying and selling sex is legal, but under strict laws and regulations. These regulations are often still used to unfairly targeted sex workers, usually regulates the time and place where we can work, and then the threat of stigma discrimination still exists and controlling of people of movement. An example, the red light districts in Amsterdam. So in Amsterdam, sex work is legalized. So they're given a specific place where they're gonna be working. But that also we're not advocating for because it comes with lots of controlling. So we also, it's the law that is implemented in Sweden. Buying is criminalized, selling is not. So that means my client is allowed to sell under this law. My client is allowed to buy, to render my service, but, or I'm allowed to render services and a buyer is criminalized. But then it doesn't make sense also because then you cannot advertise with tomato. People keep passing and say, oh, they're nice. These tomatoes are fresh, but they're not buying. And we also feel that sex workers are going to be targeted because the minute I make a move, police are going to be following me because any man that is going to approach me, then they'll be able to see that this man is a client. So we can't, because as we're advocating for the decriminalization, we're also advocating for our clients because this is our work, this is our business, so none of them needs to be arrested. Because as I said, I think either yesterday in one of the sessions that, I mean, rendering pleasure services, there's no harm. Is there harm? There's no harm, right? So that is partial. The decriminalization of sex work is what we're advocating for. Only human rights-based and inclusive approach to sex work, selling and buying and brothel keeping are decriminalized under this model. Sex workers will have access to healthy human rights and to justice, and sex work will be recognized as work. This will also protect this will be protected under the labor rights and other existing laws. For an example, the Prevention and Combating of the Trafficking in Person, the Children's Act, and the Labor Act. So the decriminalization is just to put it in a very simple, straightforward. Sex work will be recognized as work. So therefore, we'll be able to benefit just like any other employee. So something that I think I need to pose to you guys to think about, because currently sex work is criminalized. If we do not advocate for the decriminalization of adult sex work in the country, all the perpetrators, everyone that is even exploiting our children, they will continue. The decriminalization need to give us an agency and the government to take control of the industry, to know who is where, because as you see, Sonke, we do not support underage, we are against the trafficking, so we don't work with underage completely. So we work with 18 years and above. So in that way, we'll be able to know who is standing in that corner and she's 46. Unomsa is standing in that corner and she's 46. Then you are able to control the industry, and I don't believe there will be any trafficking that will be rising if then sex work is decriminalized, because even sex workers themselves, they will be able to speak out if they see such criminal activities happening. Because as Usi Sonke, that's why we are advocating and leading. We do not want any criminally associating activity to us. But it does happen because then the law is not supporting us, and then I sometimes feel that if I'm friends with the pimp, he's going to be looking after me, and the pimp is pushing drugs at the same time. And drugs are killing a community, not only sex workers, but drugs are killing communities. And we're not saying people that are taking drugs are problematic, but it just become a matter of people, they do as they please. So we need to be able to control the industry. So the decriminalization is the only remedy to solve all the problems that communities are bringing to our attention. Because the decriminalization is not about the sexual intercourse. We are engaging into business in any way, whether we are criminalized. So the government needs to open its eyes to say, let us decriminalize so that we take control. In New Zealand, the sex work is decriminalized. There are policies that are put in place. Like if a client does not want to use condom, a sex worker has every right to go and open a case. Isn't it that ways of curbing HIV? You know, we're talking about HIV. So there will be some policies that I think will put in place that will protect the sex workers because they're also human beings. So now I'm going to take you through the road to decrim. We have been advocating for the full decriminalization of sex work over 20 years. 2007, SWET approached the Department of Justice to review the criminalization of sex work. In 2009, the Law Reform Commission released the discussion paper on whether to decriminalize sex work, inviting the submissions. 2009, SWET appealed to COSATU, the largest trade union, to support the decriminalization of sex work, which it did, and it also it has a gender conference in 2009. 2009 also, COSATU sent a submission to Legal Resources Center in support of the decriminalization. So you see, we're keeping track. We know within which years what happened. So it's been long, from 1957, we're now counting all these years. Definitely a change is needed, because decriminalization is about protecting the rights of sex workers and also giving sex workers rights to access to labor. It's not about the sexual intercourse, because the minute you talk about decriminalization of sex work, people think of trafficking. And there's laws on trafficking, so why do we mix these two things? The minute you talk about sex work, people talk about the underage, but then we cannot complain. Let's complain at the same time and have a solution. And the solution is the decriminalization, because then we're gonna be in charge. We'll be able to protect the sex workers themselves, our parents, our mothers, and none of them wants their children to be exploited. So there's a lot of work that we need to do. So the continual road to decrim, there's a Kylie case that opened doors, others to follow, but sex workers seldom induce the protection to their labor. The Kylie case, if you were to search it, I think somehow it's on media. It's one of the cases whereby a sex worker was forced by a manager to do business without a condom with that specific client. And the sex worker felt to let me open the case, because she refused and she was dismissed. So then she took the case to court. So we did not win that case because, you know, the voting of judges, I think we needed to have at least a number of 6 voters of the judges, but there were 5. So in that way, we lost the case. But at least that case, it did open doors, because then government is now aware about the sex workers. And then 2016, there was a launch of the National Sex Worker HIV Plan. I'm sure some of you were part of that, where the current president, that time he was the deputy, he even gave me a flower to acknowledge the work that we do towards advocating for the marginalized community and vulnerable community, which are sex workers. And in 2017, the South African Law Reform Commission eventually released the report from the call for SWET to review the laws. And I tell you, that report, if you read it, we'll try to get it if someone wants to read it. If you read that report, you get goosebumps, because I'm trying to understand what kind of a person would be that recommending those kind of laws. So the recommendation of that report, it came worse than the criminalization, because now it says, if then I'm caught in the sex work, I would then be taken for rehabilitation, and I'm not sexually addicted. You see, that is undermining my rights. or I would be arrested. But the rehabilitation for 6 months or whatever years that are going to be put on that, it does actually undermine my rights, my bodily autonomy. And it recommended the continuation of the criminalization. 2017, the Federation of South Africa Trade FEDUSA supported it, the Crime After Sweat and Sisonke made a submission and agreed to partner with both. 2017, again, some of political parties resolved to support the decriminalization. COSATU presented a proposal to the need of the decriminalization of the parliamentary public hearings. I'll try to be quicker because I feel it's important that you get to understand the history because you need to know where we started and how far we are. So 2019, the launch of the National HIV Plan and the decriminalization was also removed in that because on that plan we did to put it to crime because we know that achieving the 95-95 goals, the 10-10-10 goals, also the implementation of the National Sex Worker HIV Plan, it's not doable under the criminalization. So it was quite disappointing, but it has been progress waited to hear. 2020 COVID exposed inequalities towards the sex workers by the state because sex workers during that time, they were unable to get the financial support that is little. We were dependent on some of the donors and some of the political parties brought food where we distributed to sex workers. So it was quite a hard situation. Some sex workers are still actually recovering to that, and some they had to sell their things in order to survive. The transgender sex workers, they had to leave and go stay in the mountain. So we need definitely to make some a deep dive, I think, and be supported around this. 2021, a partnership with the Department of Social Development hosted the National Dialogue with Sex Workers, also the launch of the MEMEZA, which is an alert thing that you make use of if you are in danger. The dialogues that were facilitated by social development were robust. The aim was to facilitate those dialogues, a robust conversation with the government and sex workers. So the relaunch of the National Sex Worker Plan 2022 to 24, and then also cabinet approval of the decriminalization bill for first round of public comment and submission. And COSATU welcomed the cabinet approval of the decriminalization bill. I'm almost there. So when we then submitted our bill in Parliament, the call for submission of that, it was 1st December 2022. You see, this timing also were not good because it's December. We're wrapping up some projects, people are traveling, some they've taken leave earlier. The closing date of the submission for the public to comment, it was 31st January. Some people are still on leave at that time. But I tell you, it was not an easy process, this one, because, as you know, the anti-trafficker, the anti-feminist, they are well-funded, so their submissions were more than ours. And we also had to do the submission as per individually. If then I send the 3 submissions of all the panelists under my email, they are counted as one. So it was quite a lot of work because then we had to assist the sex workers to create email addresses and all of that. But the final submission to department, it was on the 30th of March 2023. Under the bill that we put in Parliament, there are only 3 asks. The removal of criminal charges against the sex workers. No one should be charged for buying and selling sex. A repealing of every law that criminalizes sex workers. Those are only 3 asks on that bill. Yes. So challenges in this process. The short time frame, number 1. A first round of submission to DOJ. Requirements was also sending through the posting letter or email. Many of the sex workers did not have email addresses. A group submissions under one email, as I stated, it was not allowed. After public comments, we submitted to the department. We submitted to Department of Justice, and the bill was sent to the state law advisor and other legal counsel for review and legal opinion. The state law advisor opinion on that bill stated that the current bill does not have doesn't pass the constitution muster because it does not include the framework for regulations. And we do not agree with this opinion as Sisonke, as we cannot discuss any kind of regulations under criminalized system. Government officials can have own bias. Because what does this actually mean? So the bill did not pass because then it did not have the regulations. How can you regulate the criminal activity? We can't. Because what we need to do first, the government need to give us a yes. Yes, we agree to decriminalize sex work, so let's regulate the industry. Because on the regulation now, we're putting some policies on how is it gonna look like, how sex workers are gonna work, from what age, and all those kind of things. Already as a movement, we have actually started to do that, because every sex worker that comes to join Sisonke, we explain that we're advocating for the decriminalizations. You need to know when you come here. Don't tell us about partial criminalization or legalization, because it's not working for us. And then we also do an assessment of age. We've got a form where we do your business street names and everything, and then we've also got a membership form where we capture your correct information in case shit happen, because it does, excuse my language, excuse my French, because it does happen. I go on the street now, or I go into a client, maybe we meet on the app and all those kind of things, I might not come back. So then for us, it's important to know what's Sibongile's real name. But also the age, that's where, because we've told the government that we've actually started to do this process. So when we're calling the government to say, come work you with us, we know that how the industry should look alike. We are the expert in this line of work, so therefore we also wanted to put it the industry that is safe, where people are not complaining about sex workers doing business in church, because they also get blessings there. There's no one in church, so people find the spots and make use of it, So those are kind of the things that I think, if government were to work with us, then we will be able to put it together to say, this is how the industry should look. We do not want people to detain how the industry should look like, because if you have not been in the sex work industry, you don't know what it's like. So the inclusive of the actually communities in that space, it is important. Okay, so what we then did, we did some communication with the Department of Justice. We marched to Provincial and the National Department of Justice to hand over a memorandum on the 13th of July 2023. The minister was given 1 week to respond, but none was received. On the 4th of August, another letter was sent to Minister of Lamula, responded to the letter on the 24th of August. The letter stated that the Department of Justice still prioritized the bill, and the reason for the delay in passing the bill is the state law advisor legal opinion, stating that the current bill is not aligned with the Constitution. The department has invited the sectors for the consultation on regulations, which happened May 2024. So you see, the problem is, the state law advisor, when they give the opinion, they know nothing about sex work. So the opinion that they gave, it's what they think it could be. So there was a time where in the same hotel we were invited to get some update and the feedback around the road to decrim. The state law advisor person was invited. And that person left feeling so guilty because she got to engage and interact with the expert of the industry. And we kind of tell him, what does it look like and why? He got a sense, a different sense of, if then I knew about this, I had knowledge, or I've met you before, my opinion on the bill would have been different. So you see that those are also some of the processes are prolonging our process on the decrim. Because then you just take someone who doesn't know about us and then you say to give an opinion on this. This person gave a different opinion because he had never met this kind of people. He had never heard about our issues and what our challenges and what our problems. What is it that we're encountering in the industry? So that also was a problem to us. So then we had to march to provincial and national department. Am I repeating the same? Oh, sorry. So where we are now, the sex work sector conducted a consultation on decrim and update meetings to a bill and its process to our beneficiaries, because we needed it also to make sure that the voice of our beneficiaries inform the input of the bill. Department of Justice, they only did the consultations in 2 provinces, which was Western Cape and Gauteng. And we felt that these 2 provinces cannot have a voice or input that will speak for other provinces. So as an organization, we decided to take the consultations in other provinces. The report has been combined and sent to SWET. We also conducted a consultation with sex worker members on regulations, because we needed the sex workers to understand what it means, their input, what do they think that the industry should look like. so that the bill will be informed by the grassroots community. As a sex work sector, our plan was targeting to submit the rework bill before the next election of March, between March and May 2024. By then the bill will be finalized. That's what we were thinking at that time. But then sort of also the process of the elections sort of like drag. But the report, it's ready. We put together all the consultations report, findings and outcome to sweat, because also they were doing some part to actually divided provinces. So a consolidated report, okay, I'm repeating the same thing. That would determine with a submission. So that report is with sweat currently, as sweat also is doing advocacy work in a different direction, because we're trying to put those processes in parallel. I would be talking with the next slide now. Sorry, my hands are full of lotion, and when I'm trying to slide, it's sort of like taking time, yeah. So in 2023, last year, SWET launched a legal challenge to criminalization of sex work. The first application is an anonymous sex worker. The second is a SWET, and many organizations are also joining as a Friends of Court. The cases against the Department of Justice and other departments that are related to laws and policies and all that. It is considered as a plan B. If law reform does not work, we believe it will take long to play out, as it will go all the way Constitutional Court. It is a long process. I'll show you a slide of what process is, so that even if there's something that you also be advocating for around policy change, you must be aware of these processes take long. We have hoped to pressure of the court. The case will push the Department of Justice to finish the law reform, and the process is so that they claim a credit for the crime rather than be forced to do it by the court way. So this is an overview of law reform process, right? If I were to check here, maybe we are on number 6, right? So these are all processes that any bill that it gets to be taken to Parliament, it has to pass all these processes. And you see, it's how many, from 1 till 12. These are some of processes that are prolonging our advocacy work, and people are dying, right? So it's just to share with you. I won't go into details on this one. Okay, so before I put, you can read while I'm talking, because I'm talkative, right? What I'm pleading as I'm standing here today, we know that there are organizations that are funded for the sex work program. And it is quite disappointing, because some of you, we have not heard you saying anything around anything that we do as an organization. Because us, we like media. Everything that we do, it gets to publish on media. As you are advocating and rendering services with the program or projects that you do within your organization, it is important that you also become part or involved. Sometimes I just wish to see this organization organizing a campaign around the decree, and then I'll be behind, not in the front at all times. It would be nice to see that, because you cannot love us when you're receiving money to do the project or the program. But then the inner issues, detailed issues that we're having challenge with, and not being addressed. And how are you going to achieve the program outcome if then the sex work is criminalized? We have had some incidents in Durban where TBHIVK is going to outreach to meet sex workers and render services. Police are following the mobile clinic. Do you think sex workers are going to access that mobile clinic? They are not. So then it is quite challenging. And I know that some of the organizations are funded by PEPFAR, and we acknowledge that, and we're very much grateful, because the role that PEPFAR is also playing in the lives of sex workers, making sure that the treatment and access to healthy services are there. We really acknowledge that, and we appreciate that. But we also need the PEPFAR organization to be behind us, not in the front, because we know the implications of the PEPFAR-funded organization. If they are calling for decriminalization, what will happen? But then, I've said this even in higher platforms, because I go global, I go everywhere. Because I think it is important to indicate that the laws around the pledge are actually marginalizing our voices. At the same time, as much as we get our services, but we need to have the 100% outcome achieved of those projects. The criminalization, it is a main barrier. So we also need to look in that aspect, how best do we do that? But we really appreciate for the services, because if it wasn't, some of the Global Fund, the projects, some of the PEPFAR, sex workers were not going to access the services because the stigma and the discrimination. I think you heard yesterday when I was talking about me trying to access the services just to service my Mercedes-Benz. Yes, see. So my last slide. So my closing remarks, law reform and the development of regulations cannot be achieved in the criminalization system. They're calling on the government to prioritize the bill. Our lives depend on it. We continue to be at risk of violence, stigma, discrimination, HIV, TB, STIs, infections that are perpetuated and enabled by the criminalization. Criminalization continues to negatively affect the implementation of the important health policies. I've mentioned the National Sex Work HIV Comprehensive Plan, the gender-based, the GPV infrastructure plan, and other policies related to sex workers' health and the social issues need all of us to work together. The decrim, healthy and social need all of us. We urge for your support in putting pressure to our government to stand and prioritize the bill as sex workers' lives are at risk and under the criminal law system. Thank you so much.
Okay, thank you so much, Koli, for such an in-depth presentation with regards to the work that's put behind, the process of decrim, and thank you for highlighting the roadmap of what it takes to be at the point that we're at. And I think it's also important to highlight that even in the National Strategic Plan, we've made a commitment that we would achieve decrim by 2026. So I think all of this work is a build-up to that, and we're hoping that we will get the political will to be able to move ahead. I'd like to call the next speaker, Ms. Leanne from SHE, to take us through some of the challenges also faced by the transgender community. Thanks.
Have you loaded my presentation? Yeah, they loaded it. It's already online. They just need to flag it here. Oh, okay. Yeah. While we're waiting, good morning, colleagues. Apologies for my voice. I'm nursing a cold from being in 3 different climates in the last week. So my talk is going to be around the policies affecting transgender people in relation to HIV, but also around healthcare more broadly. And I think I'll start off, so those of you who don't know me, I'm Leanne. I'm a commissioner with the Commission for Gender Equality. I'm also the director of SHE and a student at UKZN. Okay, I'm controlling the slides, yeah? I don't think so. Can we please advance the slides? Go back. Skip one slide. So, when we talk about key populations, who exactly are key populations? And this is going to, you'll see through my presentation why I want to start off by framing the concept of key populations. So these are groups that are defined, who are due to their specific higher risk behaviors, at increased risk of HIV acquisition and also transmission. And often you'll find that these populations are facing legal and social constraints. Key populations are an important dynamic of HIV transmission. They are essential partners in effective response to the epidemic. So in the South African National Strategic Plan on HIV, TB, and STIs, key populations are sex workers and their clients, trans and gender diverse persons, men who have sex with men, people who use drugs, and people in prisons and other confined settings. Thank you. It came with a lot of advocacy and hard work to frame trans people as a key population. Because for many years, and Jabu would know, from the first key populations guidelines that we wrote, and by the way, those guidelines never took off. So from those guidelines, one of the things that, severely challenged us was not knowing and understanding the dynamics of HIV infection within this population. And so one of the things that we've always had to do, the historical context of it, was that we had to keep going back to MSM data sets and extract that data and do secondary analysis of that data. And some of that had really shed a bit of light on can I use your laptop for presenting things? Can you open my presentation?
It's already open.
Oh, thanks.
But then you won't be able to.
No, I'll ask him to move the slides. So as I was saying, we had to do that secondary analysis of data from other key populations. And this is the importance of it, is that trans people face an intersectionality with other populations. I can be a trans person, but I can also be a drug user. I can also be a sex worker. And so this has been incredibly interesting, because we knew from the early days of defining trans people as a key population that we would have to work very hard to have the resources to conduct a prevalence study. And it happened eventually. After a very long time of doing advocacy, we worked with CDC, thanks Helen, in getting resources to conduct the first ever biobehavioral survey to determine HIV prevalence among trans women. So just defining trans people as a key population, globally, those assigned male at birth has a prevalence as high as 71.1%. And that's the recent analysis that I worked with Dr. Shyam from Canada. The most recent meta-analysis that was conducted by Stataram et al. Has also shown a global HIV prevalence among trans women of 19.9%, and the odds ratio for HIV infection compared with individuals over the age of 15 was at 66. So when we finally managed to get the prevalence data for trans people in South Africa, very alarmingly but not surprisingly, that the HIV rates among trans women have been 63.3% in Johannesburg, 46% in the Buffalo City Metro, and 45% in the Cape Town Metro. We are not at all surprised about these figures. I just want to add to that. Thank you. Advance the slide. Trans people do not acquire HIV within a vacuum, and we certainly don't acquire HIV from tap water. There's a particular context that drives HIV dynamics within this population. A study that I conducted with my colleague at the University of Fort Hare in 2018 has revealed that 71% of trans women consume more than 1 unit of alcohol per day. And a high percentage of those folks indicated that when they do take a drink to relax, they end up intoxicated. It's not just, when we wanted to make that distinction, is to say that while people who take, alcohol for relaxation in this community, it has, showed up as a means of coping with discrimination and all the other issues that the community is facing. There's no shortage of violence against trans women. It's well documented within the South African context, in the African continent, as well as the world. Trans women of color, in particular, are disproportionately affected by violence around the world. And we've seen also the link from various research initiatives that, this violence potentiates HIV infection by reducing the power to negotiate condom use, and therefore negotiating safer sex. When we conducted this research, the unemployment rate amongst trans women was at 25%, which was at that point just more or less where the national unemployment rate was at. The national unemployment rate has now skyrocketed, and it would be interesting to go back to the community and kind of determine what does that rate look like now in our community. Also to say that in the places where trans women are employed, our study found that in general, trans women don't earn more than 2,000 rand per month, which is very well below, the average poverty line. Can we move the slides? Thank you. Now that we're talking policy, I want us to shift gears a little bit and just go over the historical context of trans people and situating us within policies and national frameworks. In 2005, the first ever exclusively transgender organization was founded, Gender Dynamics, and they're still thriving today. In 2010, we issued a position paper. It was around the time when the UN came with introducing the language of MSM and WSW. And by virtue of our anatomy, we were involuntarily submerged in those research efforts, in which it was said that a trans woman's HIV risk is established in the same way that is for men having sex with men by virtue of having anal sex, without fully considering the socio-economic and cultural dynamics of HIV within the trans community. So, for the first time in 2012, we were excluded within the key populations, but not having a program to address the burden of HIV. And that came a little bit later in 2014, when Right to Care was the first to fund through the Global Fund LGBT work in relation to HIV. In 2016, HIV continued to be funded by Right to Care, but this time really just scaling down from LGBT, looking specifically at men having sex and transgender people. The same was, it was our second inclusion within the National Strategic Framework was in 2017, and that's also around the time when we also developed the strategic framework for HIV specifically to, and NSP focused particularly on the issues of the LGBT community. In 2018, we've seen WRHI opening the 4 transgender clinics in the city of Johannesburg, city of Cape Town, Gqeberha, as well as Buffalo City Metro. It was also around the same time when we launched the Bocello Trans study to determine HIV prevalence among trans women. In 2019, with push from WRHI and other key stakeholders, we've seen hormone therapy being placed on the essential medicines list as indicated for cross-sex hormones. And then in 2019, Beyond Zero was appointed as a PR, and they have been implementing successfully the Unmute program, which has yielded very good results around the country. And then the timeline goes up to the timeline. The timeline goes up to 2021 when WRHI, Gender Dynamics, as well as the South African HIV Clinician Society issued the transgender affirming healthcare guidelines. If we can advance the slide, please. Thank you. So just slightly, shifting the gear here. If you look at what is the two cascades we have, on the one side, a prevention cascade, which is looking specifically at PrEP, and you will see the gradient going down very gradually. And if you look at the HIV treatment cascade, we see, after HIV tested, we see a very rapid drop, indicated, the two indicators around people who were HIV tested for HIV, and people who tested positive. But as we go along this continuum, we also see that it declines very, very quite rapidly in high numbers. And finally, you will see that I think across all of our programs within the trans community, what we really are struggling with is the viral load suppression, right? And I'll talk a little bit about that, because one of the interpretation of that graph could be that we are not testing the right people, which kind of begs the question, where are the right people? And how are we going to reach the right people with our testing services? Because that's quite concerning. From HIV testing, if we look at that with the 63% prevalence rate of HIV among trans women in Joburg, that picture becomes all the more concerning. Because if we think about the 63%, we've tested them. Why is it that we're dropping so rapidly down there? But there's a lot of other interpretations around this particular graph. But the long and the short of it is that I want us to focus on viral load suppression. We really are struggling with viral load suppression. Is it a policy issue? Is it a socio-cultural issue? Is it funding dynamics? Why is it that we are not seemingly reaching or being able to retain folks in care to ensure viral load suppression? This is data from the WRHI program. Please advance. So I want us to look at this slide, and it looks a bit funny, and it may be exaggerated, but often when we look at transgender women's journey within the continuum of care, we kind of think of it as that blue arrow. And to some degree, it could be the middle graph, right? People come in and out of the program. But I know from experience, especially trans women, who are intersecting with other community issues, like trans women who are using drugs, trans women who are sex workers, etc., often the continuum of care looks like that scribble over there. And that's also food for thought, because in that scribble, we are not only thinking about a trans person and their journey within the HIV continuum of care, but to realize that trans people also function in syndemic conditions. is that when we go to the clinic, at times I may be looking at my HIV treatment within the middle graph, and it might look like that. But for my diabetic care, the continuum of care might look like that. There are many overlapping healthcare issues, and I think sometimes the trap that we all fall into our program is, divorcing the HIV care from all other issues that people are experiencing as part of their healthcare. Advance the slide, please. Intersectionality has become a buzzword, but I think it's so relevant for all of our programs collectively. When a trans person goes to the clinic, she may go there as somebody who faces transphobia, sexism, racism, substance use. And for clinicians, it's important to think about these things. And I put this slide here right after the continuum of care to just illustrate that with all of these things going on, all of the intersectional oppression, there's no wonder that the continuum of care looks the way that it looks. Because oftentimes, clinicians only look at a person within the context of the one issue that they are presenting within the healthcare facility. So the point that I really want to make is that services are not accessed in a vacuum. The intersectionality of it allows us to consider that, folks have sociocultural, economic, and political issues that we need to take into account when we conceptualize programming. And this is the syndemic issues that I talked about now, is to say that when one person comes to the clinic, they may present for a number of different issues, and these are often overlapping and might impact the one on the other. It's also important to note the intersecting vulnerabilities that trans women share with other key populations, which I've reiterated a number of times. The design of services that are quality, appropriate, and relevant, and placing people at the center of care is now needed. It's now needed more than ever. Advance one slide, please. So these are the policy recommendations that I want to make for us at this point. I've presented where we come from in terms of defining ourselves as a key population. I have presented key moments that have pushed the trans community forward in our access to healthcare. And I've presented sociocultural issues, political, dynamics. But as we are taking all of that in, I want to make these very specific policy recommendations that can take our healthcare efforts one step forward. So just in terms of, I don't want to say the Department of Home Affairs, because legal gender recognition for me in our programming in South Africa has been conceptualized only as work needed to be undertaken by the Department of Health, and that's not the case. Legal gender recognition could be a school system that allows me to dress in a way that I want to, or a school system that will allow me to play the sports where I feel comfortable. But I do think that we need more efforts and policy efforts and advocacy to strengthen the ideal of legal gender recognition in South Africa. So we need policy analysis and the development regarding public facilities such as bathrooms. I'm pleading with all of us, as we do our work, our advocacy efforts, or our program implementation from the farthest corner of Limpopo to the West Coast, in the Western Cape. Can we all collectively get over this issue of gender panic and bathrooms? It's starting to bore me. We've had conversations about it. We've not seen what the anti-gender movement is claiming will happen when we allow trans people in bathrooms, we have zero evidence of all the things that have been presented as threats to men or women in their respective bathrooms. There are 2 things we generally go to do there. 3 if you're feeling funky, but I'm pleading with all of us, please. The anti-gender movement is really pushing this rhetoric of gender panic and that we should all be, we should all be, have this fear of going into bathrooms when all we want to go to do in the bathroom is to relieve ourselves. Recently, we've had the Virgin Active issue that was all over the news. Mamba Online has done a very good report on that. But I just think that in 2024, that we should really not be having that conversation. There are really other things and more pressing issues that, we can and should be talking about. Educational policy development for trans people in schools. Again, this issue of the bathroom in schools, forces children out of school. Trans people are not dropouts. We get forced out. Let's please just clarify that point to say that we are not dropping out by choice, but the system, those binary systems, those dichotomous systems that you're either one or the other, those are the things that really push trans people out of the educational system. And that has such a ripple effect on somebody's personal and professional growth, which translates into lack of economic growth, which also puts us in a place where we don't get to make, good decisions around our health, and we end up with, very poorer health outcomes. Medical insurance, one of the biggest impediments for access to surgery, is a policy matter in South Africa. It is a policy issue because it is stated that medical aids see transgender, gender-affirming surgeries as cosmetic, and therefore it will mean that many of us will not go there, But the question many of us ask, what do surgeries have to do with HIV? A lot. When somebody is themselves in the body that they want and they are authentic in who they are, they will take better care. They will make better decisions about their health care. We need a South African study on that, but the global data has shown time and time again that when folks have access to gender-affirming care, we do tend to take better care of ourselves. In the article published, that we've published from the VITS data, Helen, it makes also the link to, and it shows very clearly that those folks who have had access to hormones are better retained in HIV care programs, And I think this is a very important argument to be made at a policy level. It's been a while since hormones have been indicated for cross-sex treatment, but I don't think this has filtered down to the policy levels of a clinic in Mdantsane or a clinic even in Yeoville, here in Gauteng. I don't think training has been provided. Yes, it's established as a policy, but I don't think that has filtered through, and into the consultation rooms of medical providers. But then again, South Africa is the template for saying one thing and doing the other. So what we've also seen are trans people are affected by demarcated HIV, STIs, and TB services in healthcare facilities. We still see places in which people are asked to go for testing in the container in the back. And trans people are discriminated as much in those containers as they are in the general waiting rooms of public health facilities. So we need to think about, how we are demarcating the services. Like for somebody living with HIV, go to that door. We need to think about what does that mean in the context of trans people. I believe with that, colleagues, thank you for indulging me. Oh, sorry. I'm tired. Sorry, I'm tired. I wanted to do this last slide. I didn't do a thank you slide. I'm so exhausted. But I thank you all anyways. Jabu. Oh, okay. So in terms of the K-POP's funding, I will end up on this slide, and Collie mentioned this. It is gravely concerning that not only PRs, but also SRs, who are not trans-led, who are not LGBT-led, are the implementers. Please, it's 2024. We cannot have that. We will no longer, as trans women, be peer educators. I'm sorry. Gita is today somebody who's leading a program who started in peer education. But how many Gitas are out there? How many Gitas are out there? There's 1 or 2 or 3 of our success stories of those of us who've come through the ranks and have done peer education. And I also want to make this point, and Gita and I had this conversation yesterday. By the way, none of us dreamed of being peer educators. We wanted to be teachers and nurses and whatever. But our situations brought us into advocacy because we needed to create an enabling environment for all of us. Because when you change things for yourself, you change things for others too. So it cannot be that a trans woman, when a program is started in some district, by some cis-led, by some heterosexual-led program, after 5 years, you find that same person earning 3,500, has had no personal development, has had no professional development. So I want to leave you with food for thought. In your programs, like who's driving the funding and programmatic decision-making? Please survey your organizational structures and consider whether your physical infrastructure, human resource policies, and other considerations are inclusive of trans people. For example, how much leave are you willing to give to somebody who's going to have bottom surgery? You need at least 3 months because there's pre-planning, there's the surgery, there's recuperating. Also remember that we don't want these 3 months because we are going to have the surgery in Hawaii and lie on the beach afterwards. Many of us have overlapping conditions, chronic conditions, that when we're taken through that surgery, it takes time for us to heal. It's an emotional adjustment, it's a physical adjustment. Are we able to reconcile what trans people need, for example, with the Labor Relations Act? You know? Those of us who work in NGOs, people will understand good and fine, but if it's a trans woman in corporate, how are we going about that case? We need policy development in this area. Also, at what levels are trans people employed in your program? When the HSRC first came to tell us that we want to do the prevalence study with trans people, we said to them, we won't have anything to do with you unless there's a trans person who's a co-investigator. We're not just advocates, we're scientists too. If you, those of you who have ever gone to the Global AIDS Conference, you see the clear separation of advocates and scientists. And yet many of us straddle that role every day, right? Because we're not just trans people. Some of us are scientists. Some of us have degrees in epidemiology. Put that to use, you know? And one other thing is, like, for example, how are we structuring parental leave for trans people? Are we going to call a trans man who falls pregnant, are we going to grant maternity leave? Can we understand the problematics in that, right? It's semantics, but it has such real life implications. And then finally, how do trans people shape the program? What is the level of trans people's involvement? Briefing and debriefing on Monday is not in any way decision making. So please, let's not flavor something for the way that it is not. That is not considered. It is not considered part of decision making when we are debriefing last week's outreach. When does the budget get presented to us? We want to see. Right? Because all we ever see, the level of decision making, is the 3,500 salary that comes into the account after SARS has gone through it. We can no longer operate at those levels, but I'm also pleading with community members. Like, where's the accountability? There's a key populations, big six in South Africa. The money gets moved through those 6 big institutions. And you also find that the staff are also going through all of those. You will find Gita is employed in a USAID program that will come to an end. Next month, she's in a CDC program. We don't see new faces. When we meet each other at key populations, it's like a family reunion. I don't see many new faces here. I don't. I haven't seen any new faces. I've seen the people that I've seen in 2010, in 2015, in 2020, and here we are again. I leave you with that.
Thanks, Leah. And I think you raised very important issues. I'm not going to recap them all. But in the interest of time, I'd like to move on to charity. We are running behind schedule, and we still have one more presentation, well, 2 more presentations. So, yeah, if you can lend us your ears, over to you, Charity.
Thank you, Jabu. Morning, everyone. Okay, so it's an honor, of course, to speak at this event where we are united in our pursuit for improving the health and rights of key populations. So during an interview yesterday, I was asked, why do we refer to people who use drugs, sex workers, and LGBTI individuals as key populations? And I admitted that personally, I don't like the term key populations. It's personal, obviously, but I rather prefer that we refer to them as priority populations, because that would mean that we are intentional in addressing the needs of populations that we prioritize. Whereas key populations, to me, just seems like a word that we can use to tick boxes. But I digress. I stand before you today to reflect on the urgent need to assess and rethink existing punitive policies and laws, policies that too often punish rather than support. So when we talk about key populations or priority populations, we mean those who are most marginalized. And previous speaker mentioned that these are people who use drugs, sex workers, LGBTI individuals, but also people who face the harshest consequences under punitive legal frameworks. So these laws, Coley alluded to this, they are rooted in outdated notions of morality and control. They've resulted in widespread criminalization, stigmatization, and ultimately a failure to address the very issues that they aim to resolve. So we have spoken at length and heard a lot about the decriminalization of sex work, but we also need to start talking about the decriminalization of drug use. I'm considered a drug policy expert, so my intervention will mostly speak to drug policies and the need to reform drug policies in our country. So globally, drug policies have leaned heavily on punitive approaches, often with disastrous consequences. In many countries, including our own country, drug laws have their roots in colonialism and the war on drugs paradigm, which prioritized punishment over health. We've seen decades of mass incarcerations, rising drug-related harms or deaths, and broken families, especially among Black and brown communities. These policies have failed to recognize the human rights of people who use drugs, pushing them further into the shadows where they face even greater harm. The criminalization of drug use does not only harm individuals, it tears the fabric of entire communities, and we see this in our communities every day. In South Africa, the disproportionate impact on Black communities is severe. People of color are more likely to be arrested, imprisoned, and face barriers to health and social services. And once caught up in the criminal justice system, they are often trapped in cycles of poverty, exclusion, and further criminalization. So punitive policies also drive drug use underground, much like sex work, making it even more dangerous. People who use drugs are less likely to seek health care, including essential services like HIV testing and treatment, because they fear arrest, prosecution, or the stigma that accompanies being labeled as a criminal. And yesterday's plenary session on research painted an even more colorful picture. So this, of course, further marginalizes priority populations, creating barriers to accessing life-saving harm reduction services like needle syringe programs and opioid substitution therapy. In 2018, we've seen, from 2018 and also in recent years, we've seen some policy shifts which signal change. Cannabis reform, for example, is a key example of this. And if most of you are not aware, in 2018, the Constitutional Court decriminalized cannabis for private use and cultivation for adults. So cannabis is not legal, it's just decriminalized for private use. And I think this is important to note because there's a misconception that it's actually legal when it isn't. So this is a victory for advocates, of course, in the drug policy reform space, but it is also incomplete. The regulation of cannabis remains a gray area, and economic opportunities created by this shift have largely benefited affluent white entrepreneurs, while Black communities that are most affected by past criminalization are left out. Cannabis reform should serve as a lesson, and while legal changes are necessary, they are not sufficient. We need frameworks that ensure that those most affected by punitive policies have access to the benefits of reforms. This requires targeted efforts to include marginalized communities in legal cannabis markets or legal drug markets, and to expunge criminal records for non-violent drug offenses, thus dismantling, of course, the long-term barriers to employment and education. So now when we turn to another key area where reform is urgently needed, overdose prevention and harm reduction. So on the 30th of August, we commemorated International Day of Overdose Prevention with a webinar, and we discussed the crucial need to shift from criminalization to harm reduction. Across the world, the harm reduction approach has proven to be one of the most effective ways of addressing drug-related harms, including overdoses, HIV, and hepatitis transmissions. Harm reduction is about meeting people where they are, without judgment. It recognizes that drug use is a complex issue, deeply intertwined in factors like poverty, trauma, and a lack of opportunity. Instead of focusing on punishment, harm reduction strategies provide support, such as clean needles, opioid substitution therapy, naloxone for overdose, and in an ideal world, supervised consumption sites. Countries that have embraced harm reduction, like Portugal and Switzerland, have made remarkable success. In Portugal, where drugs were decriminalized in 2001, they've seen drug-related deaths have plummeted, HIV transmission rates among people who use drugs have dropped drastically, and the stigma surrounding drug use has decreased, allowing for more people to access the need that they require. However, these are not perfect models, and we need to be mindful of the contexts. However, this does create a basis of guidelines for a blueprint. So while we are reforming our policies, we need to be mindful of our contexts. Harm reduction in Europe cannot look the same as harm reduction in South Africa. And I raise this because harm reduction services that are implemented in South Africa are tailored for people who inject drugs, and this is mostly due to the fact that injecting drug use is most prevalent in the West. However, in South Africa, our drug using communities smoke drugs rather than inject drugs. And so while international funding goes a long way, it is limited in its scope. And that's why we need to start advocating for domestic funding to ensure that government funds harm reduction services that are tailored for our context. So the key takeaway is this: harm reduction saves lives. It does not encourage drug use. It reduces the harms. It takes away the fear of criminalization. It allows people to engage with healthcare services without the fear of punishment. South Africa has been implementing harm reduction services, and we heard a lot about this yesterday. But more needs to be done, especially for priority populations who remain at the highest risk of drug-related harms and overdose. So what does it actually mean to have policies that support and don't punish? It means shifting the entire paradigm of how we think about drugs and its regulation. So instead of viewing drugs as a moral failing or criminal act, we need to recognize it as a public health issue rooted in complex social dynamics. It means adopting a human rights-based approach to drug policy, one that prioritizes dignity, autonomy, and the well-being of people who use drugs. It means investing in harm reduction programs, ensuring that access to life-saving services, and ending the criminalization of drug use and possession for personal use. It means integrating drug policy with broader social policies aimed at reducing poverty, inequality, and marginalization. We cannot achieve this, of course, without collaboration, and we heard a lot about collaboration yesterday. Policymakers, healthcare workers, civil society, law enforcement need to work together. We must be guided by evidence and not outdated ideologies or moral panic. The evidence is clear. The evidence is clear. Policies that support rather than punish are not only more effective in reducing drug-related harms, they are also more cost-effective, more humane, and more aligned with our commitment to human rights. Most importantly, and this is very close to my heart, we must emphasize the importance of incorporating youth perspectives in our deliberations. The involvement of young people, including their experiences, their challenges related to drug use, is crucial in developing effective and inclusive policies. Their voices must be heard and integrated into decision-making processes. It is essential to highlight the experiences, of course, of people who use drugs. Their stories illustrate the profound impact that policies, whether supportive or punitive, have on their lives and well-being. Empowering people who use drugs and involving them meaningfully in policy development is not just a recommendation, but a necessity if we really are to achieve equitable and effective harm reduction strategies. So in conclusion, I urge us all to continue advocating for drug policies that truly serve the health and dignity of priority populations. The transition from punitive approaches to supportive evidence-based policies is not just a moral imperative, it is a public health necessity. So let us work together to build a future where people are met with compassion, support, and opportunities for better health rather than punishment and exclusion. Thank you.
Okay, so.
Away two. Away two. Away two. Okay, thank you, Charity. So we'll hand over to Thabo to take us through the human rights element of things. And then if I can ask because we're gonna go straight into the next plenary session, if I can ask Bilia, we're firstly gonna get a presentation from Colleen before Bilia. We just needed to change things around. And then if Regina can also prepare herself, as well as Mr. Luwani and Mutenga, if you can prepare to come to the stage after Thabo's presentation. Thank you.
Good morning, Dumela, Itaola, Piwit, Itaola, LGBTQI, Itaola. I also see myself as key pops because I'm what we call libertarian socialist, or what we call anarchist. That's why when you guys pray in the morning, I always leave, because I don't believe in God. Thank you. Okay, my presentation, I think, is into two parts, because it's into two parts because, after listening to deliberations yesterday or presentations yesterday, I was forced to go and change, and I said, you know what, there's so much information that I think, if we're all working, together, sharing it will be very, very far in terms of ensuring that, especially the 95, 95, 95. Guys, we need to reach that. 2030 is just around the corner. I think even the people who are now leading SANAC CSF now, you must know that you are under pressure that, 2030 is around the corner. So, this 5 years is not going to be a simple 5 years for us. We must make sure that, all the goals that we have set ourselves, we achieve them. Do you want a memory stick? I can give you a memory stick. Emzabalazweni, 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 emzabalazweni. Bopha. Long live. Phambili. Phambili. Away, two. Away, two. Thank you, comrades. I think we are ready to commence with my presentation. I will try to keep as short as possible. It's not a lot of slides. Yeah, I mean, the topic, that I was told to look at was, assessing existing policies and laws in respect of key and priority populations. I think I would also want to agree with Ucharity. For me, there's no difference between the word key and priority. We can just keep it as priority populations, and that's it. Okay. Next slide. Okay, actually, I want to talk about advocacy and policy influence because advocacy, in most cases, that's how we are able to can influence policy change. So advocacy is a series of persuasive actions that are aimed at establishment of new policies, improve on existing policies, challenge pieces of legislation that impact negatively on individuals or groups, e.g. criminalization of sex work and harm reduction, for example, opioid substitution therapy and other drug dependence treatment. And now in practice, just to show you how you can influence policy, which is both about shaping processes and content through direct and indirect engagement with policymakers. We had public participation in respect of the NHI. If you can recall, we had the white paper, we had the bill, and we even had, like public participation. And right now, we do have, an act now. Hey, ya jumpa land. Hey, ya jumpa. Policy development, that's clear. Okay, so those are the stages that normally we follow in terms of policy development process, and in most cases, how we can influence it is because because of M&E, we are able to consider that this policy is not proper and it should be changed. That's how we always observe if policy needs to be changed, and I have to be honest in terms of the CSF. The civil society in South Africa have worked very, very well in the past 30 years, actually. If you look at, from how we used to relate with the government, where there was always protest in respect of, like access to ARVs, prevention of mother to child, there were big things that were happening, but, I must say that I was happy when President Mbeki was recalled, because after being recalled, that at least when we saw different shift, because some might say, no, you are not positive, but we are affected because I've buried a lot of my family members through HIV. That's why I am still part and parcel of an activist, fighting and to ensure that, we eradicate HIV. So, from that, during that time, from 2007 to 2009, I think that's where we saw the shift, where we saw now, with ARVs also, being available to our people. Some of the things that also that have led to, policy change through the CSF is putting people living with HIV at the center of the response, including the production of South Africa's first HIV stigma index, driving an ever-expanding and deeper HIV response. I guess, because I will share this, you'll be able to can read on your own. And also ensuring that, we inspired replication of government partnerships with civil society in other areas of health, like TB and maternal and child health, and participated in consultative processes towards development of a robust, multi-sectoral, fourth-generation national strategic plan on HIV, STIs, and STDs. And besides that, we have kept HIV high on the national, regional, and international agenda. One of the examples is the people living with HIV stigma index of 2012, which was led by NAPWA. It was followed by stigma index 2.0 in 2014, which led to us having, the South Africa's National Human Rights Plan. Because you can imagine, if we never had the stigma index, we would not have had all these 7 pillars that we had to follow to ensure that, we deal with the issues of stigma and discrimination. Now, when it comes to, rights and health, or, the law and health, I must say that, there are strides that have been achieved so far. Human rights are inalienable and subject to limitations imposed by the law. They are universal and fundamental to human dignity. Rights of the people are violated either due to known or presumed status. That's why we talk about, like stigma, because obviously once we have stigma, it's because we know or we just suspect that, a person might be, behaving a particular status. So they are stigmatized and discriminated against, and any presiding officer, especially now when we talk about judiciary, on matters like this, is placed in a difficult position, especially where there is death in specific legislation. We don't have legislation, dealing with diseases per se in South Africa. Like, for example, we had a problem of electricity. We have a minister of electricity. Why can't we have a minister of HIV? Department of Health is just too big. So we just need, maybe we must have a smaller department just for the next 3-4 years, so that by 2030, at least we make sure that we reach this target. So the presiding officers end up with the outcomes which may trigger assumptions of judicial activism or legislation through the back door. So the law is still underdeveloped and constitution needs to be tested for certainty. Testing the constitution, for example, in 96 after the constitution was passed, we used to have death penalty in this country. Now the question was, if the constitution says we've got the right to life, and the law says, you can be executed, how do we reconcile the two? Mr. Makwanyane decided to take, the government head on, and that's why even today we don't have death penalty in South Africa. And that's how, when I say testing the constitution, that's exactly what we should do. We've got so many rights, which I think all of us are entitled to. But as long as we don't test them, we'll never realize them. Those are, like Bill of Rights, Chapter 2 rights, which I think are very, very important, for priority populations. Section 7.2 is very clear. State must respect, promote, and protect, and fulfill the rights in the bill. I normally say we should always know one thing. We should never forget that the Constitution was not written to restrain citizens' behavior. It was written to restrain the government's behavior. So also equality, human dignity, life, privacy, and healthcare. Those are the most important rights that we should ensure that, priority populations enjoy them in this country like everyone. So we have precedents, in respect of the cases. The famous case which I always like, I think this is also the result of advocacy. Minister of Health and others versus TAC, the 2002 case. The case dealt with refusal by the state to make ARV drug available in the public health sector to prevent mother-to-child transmission of HIV. On appeal, the Constitutional Court held that Section 27(1) and 2 of the Constitution require the government to devise and implement within its available resources a comprehensive and coordinated program to realize progressively the rights of pregnant women and their newborn children to have access to health services to combat mother-to-child HIV transmission. And then we had the famous one. I know the Human Rights Commission was here yesterday. He might not be happy with some of how they do some of the things, but this one case is one where I always give them respect. Koilani versus South African Human Rights Commission, the 2021 case, where the applicant alleged that the article which appeared in the Sunday Sun, penned by the late Mr. Koilani, was offensive to the LGBTQ community. Therefore, it contravened Section 10, subsection 1 of the Equality Act. The late Mr. Koilani justified the contents of the article by virtue of his right to freedom of expression. That Section 10, subsection 1 of Equality Act infringes Section 16, subsection 1 of the Constitution. The objective of Section 10, subsection 1 is to ensure that human dignity and equality are not limited in the name of freedom of speech. Where speech infringes equality and dignity, the impugned section reasonably and justifiably limits the right to freedom of expression. The court held that Section 10, subsection 1 of the Equality Act is inconsistent with Section 1, subsection C of the Constitution, and Section 16, freedom of expression of the Constitution, and thus unconstitutional and invalid to the extent that it includes the word hateful in the prohibition against hate speech. We know we've got the Hate Speech Act. Section 9, the equality, and Section 10 of human dignity are closely linked. And now, some of the cases that we come across is of again versus Canadian government. These are just put in just to show, how other countries, view this issue of equality. The court held that equality dictates zero tolerance for legislative distinctions that treat certain people as second-class citizens, that demean without valid reason, or that otherwise offends fundamental human dignity. Now, the challenges that we have seen, especially in respect of laws in the country, working in silos by donor agencies. For example, if you look at the work that has been done by PEPFAR, the reports that we got yesterday of Richitze, you can just imagine if you have to combine that with what Global Fund is doing with their human rights and advocacy program. Look, yes, will be far. Now, if you can try and avoid, working silos by donor agencies, I think that would be very positive for the country. Lack of cross-sectoral collaboration. We still see ourselves as LGBTQI. We don't want to work with sex workers because it seems like we are contesting, for space. There's another problem, again, that we need to look at. Monitoring and evaluation, if we can put more resources, monitoring and evaluation also. Impact assessment also, we implement programs, but the question is, how do we check the impact of those programs? Because one thing that I've seen is that, after 3 years, the program is done, boom, gone. No impact assessment. Instead, the new PR comes in and start, with the new program. And now how are we going to assess that, there is a difference that we are making? Program providers, funding and understanding of human rights, I think it's very, very important. Lack of dedicated legal support services for KPPs, harmful gender norms and legislation, and disjointed capacity building initiatives. So recommendations, I recommend that we align national laws with global human rights treaties, collective program planning by donor agencies to avoid duplication, financial and technical support as well as skills transfer during the implementation of funded programs, leverage existing HIV programs, gender-specific interventions to improve health literacy and enhance access to health services, continuing community mobilization, and comprehensive and continuing training programs for beneficiaries, providers, judiciary, legal, and paralegals. let our actions be work in progress, not talk in progress. I thank you.
Sibonge kakhulu, Comrade Thabo, for that very elaborate presentation. I think, comrades, with the session that we've just had, and I want to thank once again the panelists that we've had in this first session, starting, of course, with our last speaker, our Comrade Thabo. By the way, as indicated yesterday, we mentioned my introductions and citing in our midst, we've got national sector leaders. Thabo heads the law and human rights sector as its national leader. Thank you so much, Comrade Thabo. Sibonge kakhulu, Comrade Charity, Comrade Koli, and of course, who am I missing from that first panel? Yes, of course, my leader, Commissioner and Executive Director Wagashiuli and Van der Merwe. I'm not seeing her anymore in the room, but I'm hoping she's still around. So with that, let's give the first panelist a huge round of applause. So that was quite a lot to take in. But unfortunately, due to time, what we would want to is pair adjusted agenda, take a short break, do tea and come back and then go to commissions. It might be worth our while to allow the second set of our speakers, there are not too many, there's just 3 of them, just to give us a little bit more input. And this time, we're zooming into issues of sustainability. So I think we do not want to go into commissions and start having deliberations without having touched on issues as they relate to the money and where is it coming from, and where all of our conversations and our programs that we are crafting, the plans that we are beginning to put in place, how would those be sustained, how would those be supported, and where would this funding be coming from? So as one does this ad lib, I would like to invite to the front, and I'm hoping all of these comrades are here, and if they are online, Sis Jabu, please indicate. But you see Nome Blia from SANAC, Colleen, and Regina. Let's see who is in the room. Otherwise, if they are all online, let us reach out to have them connect with us. Let's just check. Comrades online, are you still able to hear us? Do we have these 3 comrades online, or do we have them in the room? Not seeing them in the room. Yeah, I'm not seeing any of them. They left with the mullah. You understand the shock? We're supposed to talk sustainability and money, and the people that are to lead us with the changuras seem to have disappeared. Shock of my life. I'm not so sure if I'm still standing or if it is a figment of my Bilia, do we have you online? All right, so at least we have Colleen. Colleen is going to be speaking into harm reduction, is from Harm Reduction International. But we're not, yeah, where is Bilia? And where is Department of Health? We want to know about those conditional grants. We want to know where the money is. Hello, Bilia? Oh, no, not Bilia. Is that Colleen?
Hi, this is Colleen. Can you hear me?
Yes, Miss Daniels, how are you doing?
I'm good, thanks. How are you?
Awesome. We all ears. We thought you were running away from us.
Not at all. I wish I was there.
I hope you can see from the camera on your side that we have a full room of people anticipating your presentation. So take us away.
Okay, wonderful. Thank you so much. Hello, everyone, and thank you so much for allowing me to be here today. It's a pleasure. I am so excited to also hear about the summit. Today, I'm just going to talk about global financing as well as domestic financing. I'm the current acting executive director for Harm Reduction International. We're based in London, but we work internationally. And don't let the accent fool you. I'm actually a South African. Next slide, please. Next slide, please. Great, thank you so much. So we have Harm Reduction International tracks the funding for harm reduction globally in low and middle income countries. And in 2022, we found that only 151 million was spent on harm reduction globally. This means that we have a 94% funding gap for harm reduction. UNAIDS and others have done modeling and suggest that we need $2.7 billion annually by 2025 in order to be able to achieve our goals to end HIV. So we are not on track. Unfortunately, we continue to have a growing gap in financing. We had, out of that 150 million, we had 101.6 million from donors, international donors, and we only found 49.7 million from domestic budgets. Next slide, please. So what does that look like? Well, 101.6 million in donor funding amounted to 67% of all harm reduction funding in 2022. This was actually a greater share and a greater amount than in 2019, when donor funding was 52% of total harm reduction funding. Most of the donor funding, in fact, 73% of it came from the Global Fund in 2022. And in 2007, this was just 31%. So you can see that bilateral funding has been reduced substantially for harm reduction and is much more reliant on multilateral funding now. Well, what does this mean overall? Well, it means that actually in real terms, in real value, over the last 15 years, donor funding for harm reduction has fallen by 50%. If funding levels had remained stable and rose in line with inflation over the years, low and middle income countries should have received $202 million from donors in 2022. So you can see that what we're seeing is really quite a distressing picture for harm reduction funding. Next slide, please. We identified donor funding and from these major donors internationally. So the Global Fund provided 73% of funding, PEPFAR 8%, the Robert Carr Fund around 4%, OSF, Open Society Foundations 4%, Expertise France 3%, Elton John AIDS Foundation 3%, the Dutch Ministry of Foreign Affairs, who used to be a big donor internationally, only provided 2%. And you can see the others there are 1% or less. So the majority of the funding comes from the Global Fund, which really does make harm reduction extraordinarily unstable because we cannot always guarantee this funding. Next slide, please. So what does domestic funding for harm reduction look like? Well, we found that $49.7 million was spent in 2022 from domestic budgets. Iran topped that list with around $4 million, and followed by Vietnam, India, Georgia, Indonesia, Kazakhstan, and others. But this actually meant that only 0.4% of all domestic funding for HIV was actually put to harm reduction in 2022. This is despite the fact that HIV in people who use drugs is one of the highest prevalence rates amongst key populations. Next slide, please. So what does domestic funding look like in South Africa? Well, the main foreign funders of harm reduction are still the Global Fund and PEPFAR. In 2022 to 2025, country allocation from the Global Fund, they actually doubled their investment in harm reduction services for people who use drugs to approximately 14.8 million. And you might have heard of this from the Global Fund representative yesterday. But even with increases in funding, needle and syringe coverage, service coverage is still only 30% of the World Health Organization target, which is supposed to be 200 needles per person per year. So only 1% of people who inject opioids receive opioid agonist therapy in South Africa. If South Africa is going to reach the 2025 Global AIDS Strategy prevention targets for people who use drugs, then you would need to increase coverage of needle and syringe services by 4 times the current size, and you would need to increase coverage by 10 times for opioid agonist therapy. Because domestic funding in South Africa was only $2.5 million in 2022. Two things to note is that Global Fund did provide 0.9 million for opioid agonist therapy, and PEPFAR supported medically assisted treatment up to $1.3 million. So this is quite significant because it means that South Africa is not going to be able to achieve the targets if they don't look at domestic funding. Next slide, please. So domestic funding, as you've seen, has been almost non-existent in South Africa, with almost all funding coming from international sources. 70% of South Africa's HIV response is actually domestically funded, but HIV prevention only receives a very small proportion of national funds, around 8%, and there has been no national spending on harm reduction. And I know you're going to hear about this next program in this session, NACOSA, but I do want to highlight it here because this is the only government-funded service for people who use drugs. At the moment, government-funded services really are all about abstinence programs, which we know do not work. You need to be able to provide what a person who uses drugs actually needs, and that's harm reduction. And the only public funding comes from the city of Tshwane. This is the COSA program, the Community-Oriented Substance Use Program, which began in 2016. And this is really a great example that shows us how partnerships at the community level can actually create an enabling environment that is able to withstand political changes. And I know that you're going to hear this presentation later, but I want to highlight the fact that COSA is community-based. It is evidence-informed responses to drugs that uses and supplements existing resources. And it provides a continuum of care for all stages along the spectrum of drug use and drug-related harms. So it prioritizes risk reduction and health over abstinence, which is what most people actually want. And it does address the social determinants of drug use by reducing stigma and exclusion through education. And it gets results. We're seeing impact. It's also a good example of what happens when a government actually looks at community-based organizations as an equal partner in service delivery. This is something that most governments seem to be struggling with, is that they still do not see community-based organizations as a vital partner in the strategy to implement services. And a lot of governments we're seeing are not actually supporting community-based organizations to be able to become service providers. So, one of the things that you could look at is social contracting. If that's not available, I do believe it is available in South Africa, but how do you actually work with community-based organizations to get them to a point where they can become service providers? Next slide, please. Because community-led responses are going to be the way that we actually address and achieve the targets that we've set to eliminate HIV. Globally, there's a lack of monitoring of progress against the targets, and we have no way to hold donors and governments accountable on these targets. So community-led organizations are becoming central to that. And harm reduction is a great example of this, because many harm reduction services are able to continue to provide services even in challenging circumstances, particularly when there's donor flexibility. And we saw that with the war in Ukraine, and we saw that in during COVID-19, where a lot of community-led organizations were the ones who maintained services when governments shut down. And we're seeing that now even in Lebanon with the current war there. So we need to have funding models and processes which currently create barriers to community-led responses. We need them to change and shift. Because at the moment, what they do is they only favor the larger organizations. A lot of countries, those larger organizations are not even national. They're mainly international. That is not sustainable. If we rely on international organizations to provide services in our countries, this is not going to be sustainable. And it's also, something that comes from our colonial past, where we still want people from outside to come in and support us. So this is not necessarily the case in South Africa, but it is in surrounding countries. There's often a lack of meaningful involvement of people who use drugs in decision making. And this needs to shift and change as well, because the experts for the response to the needs of people who use drugs are people who use drugs. It is not going to be someone who does not use drugs, because you don't understand everything that a person needs. So there really needs to be some sort of investment in the advocacy and in capacity building to ensure that you have people who use drugs as seen as an equal part of not just the delivery of services, but the design, the implementation, and the monitoring and evaluation. I've mentioned social contracting in some countries. I mean, one of the biggest issues is that drugs and people who use drugs are still criminalized. And without changing this policy and these laws, we will never be able to achieve our goals. Next slide, please. So we do have a harm reduction funding crisis globally and nationally. We have become more and more reliant on the Global Fund, and thank goodness for them for stepping up and actually putting more funding into harm reduction. But it actually means that we are fully dependent on whether the Global Fund gets replenished or not. And so depending on the amount of replenishment also depends on how much then gets put into harm reduction. So if we don't get full replenishment, then it means that we do not get funding for harm reduction. And a lot of key donors for those areas that are normally not funded, like advocacy, legal and policy reform, human rights and community strengthening, a lot of the current donors have actually reduced their support for these areas of work, which means it does not get supported. And most national governments will not support this, even though the changes that advocacy brings about actually help people in the country. So harm reduction funding is really vulnerable to changing donor priorities, to political will, and to complacency. Domestic harm reduction investments are totally lacking. And there have been some reductions in countries where we used to see high levels of domestic funding. We no longer see that. And sometimes, a lot of it has to do with the way that we're also tracking this in a lot of countries. If we're not able to track community-led responses and how much money is going into it, we don't know how much we're then achieving those targets. It also means that we're faced with poor harm reduction data quality, and data, availability of that data, which means that we're using old data. I sit on the Global Fund Technical Review Panel, and some of the key population estimates I see are still from, the early 2000s. They've never been updated. How do you have a good program that is based on old data? If you don't know the exact number of people who require services, how can you budget for it? And then how can you scale up services? It's not possible. So trying to get good data is going to be something that has to become more important over the next years. And failure to embed community-led responses reduces sustainability. If you create services that do not respond to the needs of people who use drugs, they are not going to utilize those services. And so you're going to see wasteful implementation. You're going to see increases in HIV and hepatitis and other bloodborne diseases, for example. So you need to think about the sustainability of the response. Next slide, please. Next slide, please. Maybe there's a problem with the slides? Let me know. Okay, next slide, please.
You see, this is the hum that you've created. Even the computer is freezing, Miss Colleen.
It's terrified.
We were anticipating you telling us where the funds are and how we can get more. And you're
Yep,
busy
I'm
telling
good.
us
Yes, here we go.
problems in getting money.
No.
See now, you are flagging 151 million. We're getting excited. We're seeing 100 billion.
Yep.
I'm hoping this time around you are telling us this is money that is being allocated.
I'm telling you where you can find the money, yes.
Sure,
So,
awesome.
what
Let's
we're doing,
continue.
what I'm showing you here is the 150 million that I talked about that we currently have in harm reduction funding versus the $100 billion that is being spent annually on drug law enforcement every single year. So we actually, when governments tell me they don't have money for harm reduction or for HIV prevention, that's actually not true, because it's where they are spending the money, right? Most governments have money, they're choosing not to spend it in critical essential services. So we have never achieved a single thing in South Africa, or actually in any country around the world, with the war on drugs. Yet we still continue to put in 100 billion a year to sustain the war on drugs. In South Africa, when we created developed one of the most amazing constitutions in the world, we never actually changed any of the institutions to respond to them. So our apartheid police became our war on drugs police. And all we've done is we've militarized them against the community even more. Because this is the amount, we are looking at hundreds of billions of dollars that are being spent to basically oppress us. And if we reallocated just 7.5% of global drug control spending, so around $7.66 billion, it would actually result in a 94% reduction in new HIV infections among people who use drugs, people who inject drugs. The social cost of drug use will also fall. We've seen that in Portugal, where they decriminalized drugs, and it means that costs have fallen by more than 18%. In Australia, a decriminalization model also showed that it would reduce the cost of law enforcement by more than 50% and generate income for the government. And in Indonesia, if we decriminalize personal possession of small amounts of drugs, the burden on prisons and other closed settings would be reduced by 40%. Next slide, please. So what we can say is that harm reduction is investment, because it's actually one of the most cost-effective public health interventions. And we've seen that from several economic and investment cases that have shown this cost effectiveness around the world. We've got, countries like Vietnam, Kenya, Indonesia showing the cost effectiveness of opioid agonist therapy, NSP in Malaysia and China, the Naloxone distribution in several countries, drug consumption rooms in Canada and the US, where they've actually started to reduce the overdose epidemic that those two countries are facing, and integrated harm reduction services in countries like India, Malaysia, and China. It is much better to integrate services than to create separate services. So if you have an HIV service, you can integrate harm reduction, viral hepatitis, social housing, linkages to other services that people might need than it is to create all these separate services. So it's something to think about. If you have good HIV infrastructure, how can you integrate harm reduction and other services into that? Next slide, please. So one of the ways to do this is really, we have got to be able to divest from the unjust drug war and invest in justice, whatever justice looks like to you. It means we move funding from ineffective law enforcement. Consider this: if you go to a bank and you say, in the last 50 years, I have not achieved a single goal in terms of my business, and in actual fact, I've created more harm, will you get that loan? Absolutely not. But we still continue to, without questioning, we still continue to invest in law enforcement for drug control, even though we do not get any results. If you think about the way that you manage your life and your budget, would you be able to do this and sustain this and get the money and the loans and the mortgage that you want? Not a chance. So we need to be able to interrogate where our current national budgets, what they look like and where the money is being spent. Because budgets, our national budget is a value statement. Our governments are telling us exactly what they believe is important, not what we believe is important. So budget advocacy is going to be something that we need to improve, increase, scale up in terms of the work that we're doing. When we're a service provider, you still need to do budget advocacy in your community because you could have the success that the city of Tishwane and COSAP has, and it doesn't have to be that one place. It could be every city in South Africa that does this. Thank you. I think that should be my last slide, or maybe there's one more. No, thank you so much. You can also download our cost of complacency report on our website. Thank you so much for your time.
Thank you so much, Ms. Daniels. And of course, in your presentation, you cited quite a lot from the beautiful work that we see unfolding within the city of Tshwane, insofar as the co-financing of some of the work that we're doing. And of course, we're quite delighted then that on our panel this morning, we've got Mr. Here it goes, Libwane Nemutenga, from the city of Tshwane, who's going to just give us a little bit about how then, as the city of Tshwane, they've been able to make the co-financing of the programmatic activities work. And of course, taking from what Colleen Daniels has already alluded to, it's us also trying to learn from comrades within the city of Tshwane what we can go further and advocate for in our own different provinces and different districts, as indicated, learning from their own experience. But I'm not going to say much because the fine young man is already here, and please, let's give him an ear. Mr. Libwane. Is there a presentation or you just keep on here? Do you have a presentation?
Yeah, they have it.
Okay. Perfect. And if you could just proceed to move forward. Which movement on? Or I can just help you.
Yeah. Good morning, colleagues.
Wait.
Okay, thank you. My name is Libwane. I'm from the city of Tshwane. I know that amongst us, I do have my colleagues. I heard some of their voices as they were greeting. And I know also that actually my presentation has already been made by the previous speaker. Because the previous speaker has just went into detail about what we are doing as the city of Tshwane. So what I found in this type of platforms is that we just have to share our own experience and the way in which we've gone about to fund the program. So we, as indicated by the previous speaker, we run a program that we call Community-Oriented Substance Use Program. We do it in partnership with the University of Pretoria. If you can just go to... Okay. As I've just indicated, we do it in partnership with the University of Pretoria, and this has really made it easy for us to provide this service. And this initiative is anchored on the Memorandum of Understanding that as the city we have with the University of Pretoria, and this started around 2016 in terms of implementation, but It was anchored on a memorandum of understanding that was signed in 2013, which was to run for 3 years between 2013 and 2016. And the purpose of that MOU was to strengthen the collaborative ties between the university and the city, to promote intellectual capital, and to collaborate between the two parties, so that we can achieve on what is mutually beneficial to both parties. And we also intended to have a long-term relationship. As you can see, since 2013, even now, we are still on the road together. And that MOU actually became the framework that anchors everything. For that, we then had to implement separate programs or separate projects, and those separate projects had to be anchored on service level agreements. And those service level agreements will then serve as the addendum to the memorandum of understanding. And then for each project, we will then have what we call the joint working group at a project level. And in that way, we will be able to determine the specifications for what we need to deliver on, and also be able to approve the funding. And since the beginning, we have been funding the program with an average of between 30 million and 50 million per year. So I say the average between 30 and 50 because at the beginning of the program, we started with 50 million. That was in 2016. And now where we are at 30 million for this current financial year. And we will have funding also for the other 2 outer years that are part of the service level agreement. So, like I've indicated, so the memorandum of understandings gets to be renewed as and when they expire, so that we can have a sort of a policy foundation. And in 2017, there was a second memorandum of understanding that was signed with the university, and then there was another one which was signed in December 2022, which is the current one. I've already indicated some of the things that are the intention of this MOU. It had to do with the improving the socio-economic profile, the efficiency and effectiveness of the city. And we're fortunate because as a city, we find ourselves in a space where there's a lot of research institutions and institutions of higher learning, and that's why we managed to tap into this relationship. And ours had to be evidence-based, and hence we said we want to have the research capacity. And also that when we get together, we can have a better thinking capacity to develop service-oriented programs to address service delivery. And it had to be scientifically based, as I've indicated, and we agreed that we're going to exchange scientific information and technology. And what we were going to do was that we're going to do a lot of training, we're going to do skills development, and we are going to have joint seminars and conferences, and we've done that throughout this relationship. And we've had this community-oriented substance use program as one of those programs that we've been implementing. So the MOU, when I refer to the MOU, is not about community-oriented substance use program, but it's an anchoring MOU for all the interventions that we implement with the university. The current MOU has the same objectives as I've already reflected on. From what I was saying is the content of the initial MOU. So I'm not going to go through it again. And what we did for us to to get authorization is that we went through our mayoral committee, and that we started in 2015, that we went to the mayoral committee for us to get a program on drug and substance abuse response to be approved. And that program was to ensure that we develop an evidence-based response that will yield positive impact on what we intended to do in the community, and it was based on what we would have observed. If you can go to the next one. And part of that request to the mayoral committee was that we were to request that we be allowed to enter into a service level agreement with the University of Pretoria to do the research, and so that we can then be able to determine the scourge of drugs and substance abuse within the city, and so that we can be able to plan the interventions that are most relevant. And we also wanted to determine the baseline so that we can be able to know what is happening in our community, so that we are then able to come up with solutions based on what we know. We wanted to get to understand the numbers that are there, and also to say what are the recommendations that we can be able to implement. We did this in a form of a consultative process with quite a number of stakeholders, and we ended up with a sort of a summit where we were getting the inputs from various stakeholders. That research identified various gaps, and it informed how we had to plan, and the recommendations were that we needed to identify the vulnerable groups that we need to assist, and we need to be able to look at having local community for primary, secondary, and tertiary interventions, and also target the at-risk groups, and also make sure that we utilize various avenues, including sports and cultural activities. And then we came up out of that research with a new program, which was going to include the community-based rehabilitation model, or what we call community-oriented substance use program, and that will include our contact center, which is still active even now, and also working with the various stakeholders, making sure that we empower our community systems in terms of our local drug action committee, with a lot of difficulties, but we managed to sustain and do a bit of what we can. And also we also supported not-for-profit organizations coming out of that research as recommendations. And then on the basis of that, then we looked at the University of Pretoria to say, now that we have determined all those recommendations, what is it that we can do? And that's when the issue of community-based substance use intervention program was brought about. And we then took it back to the mayoral committee for its consideration. And it got to be approved, and then it was going to only be implemented when we have signed the service level agreement on that implementation. And that service level agreement meant that the University of Pretoria is sort of like our partner in implementing the community-based rehabilitation program. which was recommended by the research, and also make sure that the city manager is allowed by the mayoral committee to sign that service level agreement. I've also already indicated that then the University of Pretoria was appointed as sort of a service provider, but actually a partner. And the intention for us was to minimize the health and social economic impacts of substance use through the identification and prevention and resolution of substance use disorders, and using community-oriented primary care approach. And to prevent, treat, rehabilitate, and reintegrate people affected by substance use, and through a community-oriented primary care approach, which the previous speaker has spoken on. And since then, we've been moving forward with that. We've had that first SLA, we've had the second SLA, and we're now on the third SLA, which is the third phase, which is to expire in 2026, which we signed recently in April 2024. And quite a lot of people always wonder how we managed to be able to get that our mayoral community to authorize us to implement the program. And with all the ODs, we still find ourselves within the allowable process. So it's not like we've gone outside any allowable legislation. So, but I know that quite a lot of people find it difficult to say where do they anchor their program and the funding. So we have motivated our funding to the mayoral committee on the basis of what the Act provides for. Because the Act provides for the services that have to be provided, and it highlights that we need to develop a comprehensive response program for combating drug and substance abuse, and we need to coordinate interventions that fall into the three categories: demand reduction, harm reduction, and supply, and also implement comprehensive intersectoral strategies aimed at reducing demand and harm by substance abuse, and facilitate the establishment of programs for early intervention. So based on that, we went to MACO and said, this is what the Act says, and then the mayoral committee listened to us and gave us the authorization to continue with what we are doing. And in that way, the Act also helps us to motivate and say, what enables the mayoral committee to allow the funding is because the Act does have the indication about provision of financial assistance to service providers, which in this instance, we are partnering with the University of Pretoria, and that funding is provided in that way, and then we pay over to the University of Pretoria to provide the services. And the Act does say that we need to prioritize needs and services for persons affected by substance abuse, and that's what we are doing. And we need to enter into contracts with service providers. That's what we have actually motivated for, and provide fund for community-based services. And that's why even the previous speaker did indicate that ours is a community-oriented substance use program at community level. So that is what anchors our program. So I won't go into the deliverables and all that. I thought the only important thing is to share how we have managed to put together a funding model for the program in the city of Tshwane. Thank you.
We seem to have some ghosts in this room. Anywho, thank you so much, Mr. Emutenga, for that presentation, and of course, the twinning as it flows from the presentation we had from all colleagues. I'm mindful of our time. We are already at 12, and we should have been starting the side conversations, taking over from these two, the morning the session. But the worry that we have is that we've got two more presentations that are left, As indicated, both of these are online from Ms. Pilia and of course from Ms. Regina, and I'm hoping singabambisane ekutheni sithathe just those last two, and of course as we move into tea break and therefore the breakaway sessions that we do that as one item combined. I'm excited to see that some of the speakers for both our breakaway sessions are already here, and I'm hoping we'll be able to brief them a little bit on some of the deliberations from yesterday to this morning, so that as we move into those commissions as well, we are able to bring some of these learnings into those engagements. Colleagues, we've got Mary Regina online. Let's just check. Ma'am, are you there? As indicated, she's from the Department of Health, and the idea was that hopefully, unlike the first speaker who gave us from Harm Reduction International, at least some of the challenges that we have insofar as funding our work as it relates to working with key population PWOD, and the exciting news that we started to consuming as they came from the city of Tshwane, and how co-financing from a municipal perspective, working with our communities in co-financing programs that bring about change for key and vulnerable populations. And of course, from his presentation, we're focusing on, once again, people who use drugs. I'm hoping, Ms. Regina, and I'm doing this with the hope that you'd respond so that we know that we have you online, able to engage us. We can see that you're online, but we are not hearing your voice. So if you can indicate that you can hear us and you're able to continue with your presentation. We have loaded it on our side. Mary Regina? Are we still not finding her? In the meantime, can I check? Sis Pilia, are you online from SANAC?
Yes, I am. Can you hear me?
Sure. All right. Do we have your presentation ready?
Yes, I showed it.
Sure. Maybe because we're struggling to find Mary Regina, let's jump into you in the interest of time.
Colleagues.
Okay.
It looks like she is coming in.
Is she coming through? Perfect. Ms. Regina, let's go for it. She's with the Department of Health, and of course, we're looking at the conditional grants. And I'm hoping with that, you can take us away with your presentation. Mary Regina?
Okay. Thank you so much. Can you remove this presentation, because I've just got a call now from Jabu that in the interest of time, I need to reduce and just to refocus only on the conditional grant. So if ever maybe you can stop sharing this, then I share my slide, the site.
All right. We do apologize, and we do appreciate your being accommodative. Jabu, you are very naughty. All right, so comrades from IT, if we can take down this one and allow Mary Regina to share from her end. Yeah. And once again, we appreciate your being accommodative. So we're gonna shoot straight into condition. Really the worry, Mary Regina, is, we've been talking about our needs and issues as key populations. We've been looking at research, we're looking at where things are at. And just when we're supposed to be talking sustainability, people started taking us back to, hey, we need more money, and where money needs to be moved from. So we are hoping that taking on from how Colleen has already started, Mr. Nemutenga, looking at where money is and how we can partner to do better for our communities, that you are continuing on that line. So please, let's launch into your presentation insofar as community grants, therefore. Apologies for the pressure.
Thank you so much for those colleagues, and then for also affording the department an opportunity just to talk to the HIV prevention and also the conditional grant. There on my presentation, I'll just be short. My presentation, I've got only 5 slides. if I'm not mistaken. Then I will be talking through those 5 slides. I must just say, colleagues, that the first presentation, it really covers the HTA program, because our funding, it is mainly through the HTA support, which is the high transmission area. So the conditional grant that I will be talking about, it is through the high transmission area that is really supporting the key population and also the vulnerable population. So I did indicate to say that through our domestic funding called the conditional grant, we are supporting the key population. And then again, we are also supporting the 9 provinces and all the district with HIV prevention for the key population, or the HTI program. And the aim there is to make sure that we reduce the incidence of HIV amongst key population, and to ensure
Perhaps, Yolande, in the meantime, can we just double check our breakaway sessions? Are they still the same venues as yesterday? We're using Ushaga, King Ushaga, just on the courtyard. Rights and needs of transgender community. All right. So colleagues, in the meantime, you'd realize in the last page of our agenda, we've got those 2 commissions. So the first one, Track A, we're gonna be just next door, or Tambo 2, where we're gonna be deliberating on young key population guidelines. And of course, as indicated in the morning, we are excited to be having comrades from Department of Basic Education, LICO, Department of Health, again, Ms. Regina, and of course, Umam Cindy from DSD, and some of our fine young speakers that are going to be gathered then, of course, across the courtyard in the King Shaga room. We will be discussing rights and needs of transgender communities, led by Leonie, and of course, Ms. Gita, I'm hoping you're the one from Gender Dynamics that is joining us. Lien, I'm assuming you're from She. If not you, I saw Rose is in the room, and of course, comrades from Access Chapter 2, Grayson Taylor, are you in the room? Not yet. Joy Cindy, we had seen you before from Gay Umbrella in Northwest. So if you are traveling with Joy Cindy and Grayson Taylor, please ask them that we're going to be moving swiftly to the rooms next door in a few, if they can just hang on. Ms. Regina, do we have you back online?
yes.
Perfect. Somehow we still don't see your presentation, but we'll allow you to continue and then we'll catch up with you due to time.
Yeah, I have just sent my presentation to Jabu just now. Maybe she will just indicate whether she has received. But anyway, let me just continue with the presentation in the interest of time.
Thank you so much.
So, as I've indicated that the HTA program, it is mainly in the 9 provinces where we are really supporting the provinces with making sure that we are having the essential commodities for HIV prevention, like, for example, your biomedical intervention, your workforce, and others. And then in terms of your biomedical intervention, we have already mentioned that We are supporting the key population with regard to HIV testing services. So we are supporting the key population with STI point of care and also the rapid diagnostic screening. We are supporting with PrEP and PEP. We are supporting with condoms and the lubricant, and also offering the ART and also the vaccination. And then in terms of the workforce, so we are supporting with peer educators, with the staff that are really supporting the HTA side, because the HTA side, how we have structured them is that we are having the primary health care trained nurses who is managing our HTA side, and also who is also trained on key population, and then who can be in a position to support the key population. And then we do have the NGOs and the key population through our small grantees. And then other things that we are also doing is and then we are only funding what is in the policy. So whatever intervention that is needed, it should be in a policy, then we are able to support it. And then colleagues, as the previous speaker has just presented, we are also faced with the same challenges that it is faced by the whole world, whereby we are seeing that our funding, it is mainly going to HIV, I will call you, it is going to HIV prevention, to actually ART, and then we are seeing that only 11% it is funded through conditional grant. The whole funding, it is on the ARV and care and support program. So when you look at my slide there, I said that 74% of our grant is mainly from the government, which is actually funding 74% of HIV prevention program, and then PEPFAR is funding about 17%, and then Global Fund is funding 7%, and then 2% only to a private sector. And then I've indicated that in line with the above, for 2023-2025 financial year or plans, the conditional grant has planned 22.9 billion to support the HIV program. And then based on this 22.9 billion, of which only 11% is spent on HIV prevention. So the message here, colleagues, is that let's push for the HIV prevention intervention, because the grant, the whole grant really is going towards HIV, especially the ART care and support, and only 11% it is for HIV prevention. And we know that we are managing HIV prevention. So from this meeting, I'm really expecting to say, how do we make sure that at least 50% of this grant, it is also going to the HIV prevention program. But remember, what I have just said is that whatever that we are advocating for, it should be in a form of a policy. So I think that is that from the conditional grant. I don't know whether you've managed to hear me. Colleagues?
We did.
Yes.
This is Celia.
Yes. Colleagues in the house, did you manage to hear me?
Hi, Mary Jana. Yes, we were able to hear you in the room. Thank you.
Colleagues?
Can you hear us?
It looks like there is a problem. Colleagues?
Can you hear us, Ms. Regina?
Yes, I can hear you. Did you hear me?
So In between the knocks and the clicks and everything, not so sure what's going on with our technology this morning, but there seems to be a ghost on our lines that's sabotaging us for a moment. But let's do this. We've already seen, at least for those of us that were able to log in online, that you've shared your presentation and the guys at IT have it. So I think colleagues in the room, I really want to beg your pardon insofar as this is concerned, and to say that we will probably engage you with the slides a little bit more as the slides are shared with you. But that from what you heard, I'm hoping that as we summarize the session, we'll just touch on some of the key points, Ms. Regina, that you made, so that as we go into our commissions, at least we've taken that into consideration. I think especially because Leonie and Jabu are here, they've already got access to the presentation. They could bring some of the key points into the two commissions that we're going to be having. So with that, I really do apologize, but I want to thank you for having made time to make that presentation for us. Hang tight, because you'll be in one of the commissions as we break our way. So perhaps at least the commission that you're going to be in, I think that's the one where we're looking at adolescents and young people. Adolescents and young key population guidelines. You'll be in that session, so at least people within that session would benefit from having you engage a little bit more in that context. But colleagues, let's take the last one, Ms. Bilia, so that we can take tea and move into our respective commissions. I see some people have already started going out to take tea. Certainly for the people online, that's not a benefit for you. Ms. Bilia, if you can come through, let's see if we can see your slides. Colleagues at
Do you want me to show, or do you want it to run from that side? Because I shared it with Jabu yesterday.
Let's try running them from the side.
Thank you.
But you may start.
Okay.
Awesome.
My apologies for not being with you. I'm coming down with flu, so I thought I would better be home than go and infect everybody there. So thank you so much for awarding us the opportunity to talk to sustainability in terms of priority populations interventions. So my slides are not that many, but I want also to acknowledge the presentations that have been done by the former speakers. I know Helga yesterday, she talked to donor funding and sustainability, which is what I'm going to be touching on. And this morning, I know Colin also zoomed into the global sustainability issues in terms of priority populations, which also I will touch on and zero into our context in the country. So my presentation is mainly based on the findings of the NASA, which is the National AIDS Spending Assessment. We did it for the results are from 2017-18 to 2019-2020. Currently, next week, actually, we are starting the other NASA for the 3 years up to 2023. And also when Liviane was presenting, I heard him talking about evidence-based through research. And this is what we are encouraging from the strategic information perspective. We are saying we need to work with evidence-based, and we are speaking and preaching a culture of data demand and data use. That's why we are presenting sustainability from the NASA results. Next slide, please. Thank you.
Sure.
So from the NASA, I thought I should just give a background to those who really don't understand or know what NASA is. Like I said, this National AIDS Spending Assessment, it answers certain questions that I'm going to be presenting, and also to align to the importance of this sustainability issue. And also it talks to the uses of the NASA data, zeroing into our culture from the strategic information space to say data use and data demand. And also it talks about sustainability of NSP interventions by financing entities. Next slide. So in terms of the questions that the NASA is attempting to answer, I have already alluded that currently the results that I'm talking about are from 2017-18 to 2019-2020. From back then, we have SANAC has engaged a very experienced organization, SIGA, that Center for Economic Governance and Accountability in Africa. That's the full name. So we have engaged them in the previous NASAs for consistency. And in the NASA that we are starting again next week, we are engaging them also to lead while we just give them technical assistance. So these are the questions that the NASA attempts to answer. Adequacy. Do we have adequate funding to ensure that we implement all our interventions, our priority keep our priority populations interventions, so that we end HIV or AIDS as a public health threat by 2030. So we're talking to allocative efficiency. We need to know the total cost compared to NSP costs. And also it talks to financing, who pays and who purchases. Who pays, we are talking to the funding entities, and who purchases as well. And then financial entities, the sources, dependency. Are we self-sufficient as a government, or are we dependent? We'll see that shortly. Then financial agents as well, strategic purchasing and revenue. What mechanisms are used to finance the schemes, pooling, insurances, the direct transfers, and then financing schemes? What modalities are used through which beneficiaries access services? So those are some of the questions. Next slide, so that we finish the questions that are attempted by the NASA. It also talks to provision. What cost components, production factors, which are inputs, are we practicing technical efficiency? Who provides the services? We are talking to providers, response actors, and mapping those service providers in line with the priority populations interventions, and then service delivery modalities. What are the service delivery models? And it also answers questions on utilization, who benefits, beneficiary population, focus on key populations or priority populations, equity, cost per output, what was provided, the aid spending categories, allocative efficiency, and value for money. Next slide, thank you. So we are saying, what are the uses of NASA data? Remember, it's a project that covers expenditure over 3 years, and the one that we are starting next week will also cover 3 years. It tracks spending from all sectors according to the country's priorities outlined in the National Strategic Plan. And remember that is our leading document in terms of HIV implementation, AIDS implementation as well. Also, it includes TB and STIs. So we are looking at the National Strategic Plan. What is it that we need in terms of spending? And then global fund requests for funding. They use also that the results of the NASA or expenditure data. Like currently the funding landscape, the most recently one that was just submitted is the GC7 funding landscape. It also talks to sustainability planning, understanding the current donor dependency. And then we also use it to report on global AIDS monitoring, which we call GAM reporting, to use AIDS spending categories arranged by the 2016 high-level meeting commitments, and under the GAM is indicator 8.1 for those who know it. Flexible to include new services, e.g. the PrEP, KPOPs, and also the prisoners and transgender, TB, etc. Next slide, thank you. So the other uses are the AIDS spending categories can track expenditure according to the resource needs categories, service with proven impact, allocative efficiency, meaning that we look at the most needed areas where we can put our money, so that at the end of the day we can say this is cost effective. Allows for the measure of the funding gaps for financing and resource mobilization, and an analysis of production factors, which are inputs, cost drivers, giving some insight into technical efficiencies. And it also leads to routine collection of financial data. So for example, currently I said the NASA is for 3 years. Under the Strategic Information Unit in SANAC, we are now using what we call the BASLI tool. We are just piloting it so that we have annual expenditure reports to guide us as we implement these interventions. Allows for time trend analysis But from Colin's presentation, she also spoke to this slide, but at a global level. So I will start. Let's look at how I will, first of all, maybe talk to the colors. The red maroonish, it talks to the public sector funding. The green, it's only on one, it's actually on two, it talks to the private sector, which are medical aid schemes. That's the private sector that we are referring to. We are not referring to the entire private sector. We still need expenditure data from them. Then the blue, it talks to the international funding. The orange, yellowish, it talks to the gaps. So any orange, for example, I wish I had a pointer, or the person running the slides, can you please help me to point? For example, we start from the top. If we look at vulnerable children and youth, we are happy because a larger proportion, almost 90% of the funding is coming from the government. That is sustainable, and we are happy on that. But look at the second from the top, transgender. It's blue, only funded by international donors according to the NASA funding, NASA results. So transgender population, the funds are 100% coming from donors. And if we're talking sustainability, what are we saying if we have that scenario? We go on to training of healthcare workers. About 70% is coming from government, which is good. But there's 30% also coming from donor funding. So at least the government is trying that area. And then where I belong, systems for data, it's only less than 10% that is being funded by government. And throughout from yesterday, we were talking about evidence-based. So if we cannot fund our systems for data as a government, what are we saying? Because almost 90% is funded by international donors. We go to surveillance and studies, research and evaluation. I know from Swane, Livwani was talking about research. So you can see research, the government is funding less than 20%. And then the other 80% is from donors. So what are we saying in terms of research? Currently, we are talking about having a country research agenda. So if we're only funding about 18% and then the rest is coming from donors, is that sustainable? And then when we go to supply chain management, we clap hands for our government, 100% funding. And then the social behavior change, you can see the gaps, government about 12%, and then the donors, just a little portion, the gap is there. You can see that big gap. And then people who inject drugs, again, 100% funded by donors. So what are we saying in terms of sustainability? Maybe I will skip others so that I understand we are pressed with time. PrEP, also 100% funded by donors. PMTCT, big yes to the government, funding over 90% of that program, which is good. And then we go on to another one, which is surveillance studies, research and evaluation, almost 95% funded by international donors. Human rights related barriers, and we're talking about human rights, even our World AIDS theme this year is talking to human rights, 100% funded by donors. What are we saying in terms of sustainability? Then we go on to community systems strengthening. We are saying, I know Colin talked to communities, empowering communities, but it's 100% funded by donors. So this slide will help you even in the commissions to say, where are we in terms of sustainability? Perhaps let me end there. I know the last slide is just to say thank you so much for awarding us this opportunity. And if you want to know more about the NASA, please contact us. We have the data in our situation room, which is the National Data Repository Visualization and Analysis Platform. Thank you so much for the opportunity.
Ms. Pilia, I have no words. That last slide, yeah. Thabo, we're in trouble. Koli, we're in trouble. Looking at you as national sector leaders within civil society, where most of us organizations implementing this work are currently supported as a result of being within those structures. A lot of our work is donor supported, externally supported. It basically means our work is not sustainable. We're gonna move into our breakaway sessions. And within those 2 sessions, I'm hoping when we look at young key population guidelines, we will also try and factor in the concept of sustainability, innovation, and budgeting within that space. But also as we look at our rights and needs as transgender community, Leanne has already painted us a picture of where our timeline comes from and where things are at. But she also spoke quite a lot insofar as intersectionality. Some of us are drug users, some of us are sex workers. And with Collie's presentation this morning, we were painted a bleak picture of where things are at insofar as decriminalization. And of course, on this end, we also have got issues, as Mrs. Charity touched on them insofar as the criminalization that goes with us being drug users and the stigma attached to it as well. So as transgender communities, whether trans men, whether trans women, we got quite a lot that I'm hoping would come out of our deliberations. But once again, that in our deliberations, we touch on issues around how we can innovatively scale up, reach further marginalized transgender communities within us being a marginalized and vulnerable group ourselves, but also insofar as finding different ways of sustaining our work. Colleagues, thank you so much for this morning. And once again, we do apologize for taking a little bit more into your tea time. If we could have a working tea as we diverge into our 2 groups, King Shaga, we're gonna be looking at the rights and needs of transgender, of course, next door, track A. We're gonna be launching 2 conversations on young key population guidelines. And of course, I'm expecting the speakers to join us there. And as indicated, Sis Jabu, Nino Leone, don't forget to take the presentation from Umam Regina so that we can also see what comes out of it as it is included in our engagements. Colleagues, with that, thank you so much for this morning. We see each other back here at, let's see, it's 12:30. Do you think by 1:15 we can try? Do it in 45 minutes, back here, conclude, go to lunch once and for all? Sounds like a plan? Someone in this room is not going to be able to drive home, so please check your pockets and see if you haven't lost your keys to your car. I'm happy to take it, but you know, as we move out, take your pockets and make sure you come claim your car keys.